Okay, so today we're going to discuss a very important topic, that is germ cell tumor of the testis. This is the most common malignancy that is seen in the testis, and it is of paramount importance because it is a highly curable disease, right? So we should know the ins and outs of GCT of the testis because these patients can be taken up for curative treatment in most instances, and we should not miss out on any of the minute details regarding this tumor. Okay, so without any further ado, let's get into the session for today. So first, let's start off with the incidence. So the incidence varies across the globe. If you take India, for example, it is only at an incidence of 0.3 patients per lakh. Okay. Now, if you go to Scandinavian countries, right, the incidence is a lot higher. So it is around 10 to 15 patients per lakh population. Okay. So it is a lot higher in the Scandinavian countries. The reason that is seen in most studies is high expression of c-KIT ligand within the Scandinavian population, right? Because of that, it triggers the pathways for the emergence of germ cell tumor of the testis. Okay, that's the possible hypothesis as to why it is present at a higher incidence in the Scandinavian countries. Now, let us get into the signs and the symptoms. Now, of course, the most common thing that you will see is a painless lump in the testis, right? So you'll most commonly see a painless lump in the testis, and pain can sometimes be there. So, and usually if it is there, it is a sort of dull aching, dragging pain that is seen. And pain mostly occurs, although it is mostly painless, pain mostly occurs when you have other things going on. So you can have bleeding, right? You can have an concomitant infection, orchitis or epididymitis, right? You can have torsion, which is very rarely seen. You can have infarction, right? So infarction of the testis can also occur, mainly seen in tumors with rapid growth, for example, with an embryonal or a choriocarcinomatous component, right? And of course, you can see it with advanced disease, right? So, example, if it's involving the scrotum or extending beyond, there also you can get pain. So, those are the instances where you will get pain. Now, very often, a lot of the patients will present with some sort of trauma to the scrotum or the testis, right? Now, here it is important to note that trauma is not causative as such, but it can lead to discovery or it can bring attention to the testicular swelling. Okay, so that is the importance of trauma. It's usually preceded by a traumatic incident that's commonly seen, but here it's not causative, rather it brings attention to the testicular swelling. Then you can also get a swelling in the opposite testis, right? Now, the chances for this occurring are very less. So there's only a 2 to 3% chance of a testicular malignancy in the contralateral testis, right? But it is something to look out for. Now, apart from this, what all can you see? So you can see swelling elsewhere. So usually in other lymph nodes, swelling can be seen. This is usually seen in the advanced state of a GCT. But when you see swellings in other lymph nodes, for example, the supraclavicular lymph node, right, you might think about lymphoma as well. That also needs to come to your mind. And you can also see fever, right, and weight loss. So fever and weight loss is, it can be seen if there's a concomitant infection or if there's an extensive disease burden. But once again, other nodal swellings elsewhere, fever, weight loss, lymphoma needs to come into your mind over a GCT, right? Now, apart from swelling in the testis, the most common symptom that you will encounter is a lower backache. So lower backache usually points towards involvement of the retroperitoneal lymph nodes. Okay. So this is the most common site of metastasis in a testicular GCT, right? It spreads to the retroperitoneal lymph nodes. Usually testicular GCT spread in a very, you know, uh, regular pattern, that is from the testis to the retroperitoneal lymph nodes, right? But in certain rare cases, such as, for example, an embryonal carcinoma, in that scenario, you can have skipping of the retroperitoneal lymph nodes. It can spread directly, for example, to the lungs. But in most cases of GCT, especially seminomas, they spread in an orderly fashion to the retroperitoneal lymph nodes. Okay. Now, it's important to note here uh, the importance of side of the testis, right? So if you have a left-sided testicular mass, that is a GCT, it will spread to the para-aortic nodes. Okay. But if you have a right-sided testicular swelling, then it usually spreads to the inter-aortocaval nodes. Okay. So this is the usual drainage site of a left and right-sided GCT. Now, you can have right to left-sided nodal drainage. So if interaortic cable nodes are involved, it can also spread to the para-aortic nodes or the pre-aortic nodes. But it is very uncommon to see left to right retroperitoneal nodal drainage. Okay, so right to left is more common. So that is something that you need to keep in mind. So from here, it can spread, to other sites as well. So the next set of symptoms is cough and dyspnea. So cough and dyspnea are seen predominantly with lung mets, right? So lung mets can be seen. And you can also have mediastinal involvement. That is, the mediastinal nodes can be involved, right? It can spread through the retrocrural nodes to the mediastinum. Now, a very important distinction here is that in a primary mediastinal germ cell tumor, right, it will usually spread to the anterior mediastinal. But in a primary testicular germ cell tumor, it will spread to the posterior mediastinum. So that distinction needs to be made and noted. Okay. So that's how you can differentiate between a primary and a secondary mediastinal germ cell tumor. If it's secondary spreading from the testis, it will spread to the posterior mediastinum. Okay. Now, of course, apart from this, you can get a wide range of symptoms. You can get bony pains if there's bone involvement, which is rare. You can get, jaundice, right? You can get plus abdominal pain, especially if there are liver mets or it spreads to other abdominal sites, right? And also you can get symptoms of headache, nausea plus vomiting, seizures, if there is brain mets. And brain mets are usually seen in aggressive GCTs such as embryonal as well as choriocarcinomatous GCTs, right? Now, apart from this, you can also see patients presenting with gynecomastia. Okay. Now, gynecomastia can occur in the setting of GCT for various reasons. So it can be due to an increased beta HCG, right? So if you have embryonal or choriocarcinomatous component, the beta HCG can rise and it can lead to gynecomastia, right? You can also see other symptoms such as tachycardia due to activation of the thyroid receptors as well. This could also be part of a testicular feminization syndrome, right? Which is one of the risk factors, as we'll discuss later on, for development of GCTs. Then certain rare non-GCT testicular malignancies, such as Leydig cell tumors can also lead to gynecomastia. And of course, if the testicular GCT occurs as part of a syndrome, there also you can get uh, gynecomastia. It's just Klinefelter syndrome. Although in Klinefelter syndrome, it's important to know that you see mediastinal GCTs more commonly than testicular GCTs. But in the setting of GCT overall, it's one of the causes for gynecomastia. Okay, so these are the wide range of symptoms that we tend to see in a case of testicular GCT, and these are the reasons why those symptoms are seen. Now, the next thing that we need to look at is, of course, the risk factors, right? Just very important to know. So when it comes to the risk factors, one of the big risk factors is germ cell in situ neoplasia. Okay, so this is a precursor lesion that can have a high propensity to develop into GCT. So usually if you have GCIN, the 5-year risk of developing GCT or germ cell tumor is 50%, and the 7-year risk is 70%. Okay, so there's a high risk for developing germ cell tumors. Now, the second risk factor that we're going to talk about is cryptocordism or an undescended testis. Now, if you have this, you're at an increased risk of developing germ cell tumors. Okay, so it is important to note here that to decrease in an infant with cryptocordism or undescended testis, we can do something called orchidopexy. Okay, orchidopexy to decrease the risk of development of germ cell tumor. Now, the thing is that it is done usually at 6 months. It is recommended to be done between 6 months to 1 year after birth. We do not do it before 6 months because in a lot of patients, there can be natural descent of the undescended testis into the scrotal sac. Okay, so we wait till 6 months and we do it between 6 months to 1 year. And if you do it in that, there is uh, a great decrease in the risk for developing germ cell tumor. Okay, so that is when you have the greatest decrease in risk for germ cell tumor, but the decrease in risk is there up to 6 to 12 years. Okay, and with each passing year, the risk of developing the quantum of decrease in risk decreases. So you should do it between 6 months to 1 year, but you can even do it up to 6 to 12 years, ideally as well. But the quantum of decrease in risk will decrease as each year goes by. Now, after this, 12 years or so, beyond that, there is no further decrease in risk for doing by doing orchidopexy, right? So still we should do it. So beyond 12 years, you should still do orchidopexy. The reason for that is not because you're decreasing the risk, but by doing orchidopexy and bringing the testis back into the scrotal sac, even if the patient develops a GCT later on, you could identify it earlier than if the patient still has an undescended testis. So you do orchidopexy in patients even greater than 12 years of age, even though there's no decrease in development of germ cell tumor, but you can detect it earlier if it develops in that undescended testis by doing orchidopexy even beyond 12 years. So I hope you understood that point, right? So that is also very important. So coming to the next risk factors is family history. Okay, a family history. So especially the male first degree family members are most important. So if you have a brother who has germ cell tumor, you have a 6 to 10 times increased risk of developing germ cell tumor. If your father has germ cell tumor, then you have a 4 to 6 times increased risk of developing germ cell tumor. Okay, and of course, if you're if the patient is a twin and the other twin has germ cell tumor, then the risk is much higher. So it is around, for dizygotic twins, it is around 30 to 40 times increased risk, and for monozygotic twins, it is around greater than 50 times. So these are the risk for developing GCT based on your family history. Okay, now moving on, testicular dysgenesis. So testicular dysgenesis, including, we already spoke about cryptorchidism, right? Hypospadiasis, infertility, a combination or constellation of these features, which forms part of testicular dysgenesis or testicular feminization syndrome, can also put you at an increased risk for developing GCTs. Okay. There's also some data that marijuana use can put you at a risk for GCT. And now, coming to the genetic causes, many syndromes have been associated with an increase for GCT, such as Klinefelter syndrome. Of course, this is for mediastinal GCTs more than testicular GCTs. Then, of course, Noonan syndrome and also Down syndrome will put you at an increased risk. Okay. And now, certain infections can also put you at an increased risk, such as HIV, for example. And of course, if you have a contralateral testicular malignancy, the opposite testis is at an increased risk. So these are the very important risk factors that you need to be aware of that can predispose you to a testicular GCT, right? Okay. Now, moving on, let us now look at the differential diagnosis for a case of GCT, right? There are many DDs for a GCT. It is very important to know from an exam point of view as well as to what those DDs are. And we'll be dividing these up by age. So when you start off with a neonate, so DDs for testicular swelling. So for a neonate, the most commonly seen one is a juvenile granulosa cell tumor. Okay. Now, when you go from 1 to 20 years, there are many things that can be seen. So you can see a prepubertal yolk sac tumor or a teratoma. These can be seen, right? You can see a testicular malignancy as part of an acute lymphoblastic leukemia or a lymphoblastic lymphoma in this age group. You can see paratesticular RMS can also be seen, right? And you can also have sex cord tumors that can present in this age group. Now, as we move on, between 20 to 30 years, right? So you can say 20 to 35 years as well. You will usually see non-seminomatous germ cell tumors of the testis. Okay. Now, as we go even further, in 30 to 50 years. So in this age group, you will usually see seminoma of the testis. Okay. Now, as we extend even further to greater than 60 years of age, this is when most commonly you'll see lymphoma. And the most common type of lymphoma seen in the testis is DLBCL, right? Diffuse large B cell lymphoma. You can also get METs, usually from the prostate, from a renal cell carcinoma, or from melanoma. Okay. You can also have something known as spermatocytic seminoma as well. Okay. And of course, certain sarcomas can also present as a primary testicular lesion. So this is the division of the differential diagnoses for a testicular swelling based on age, which is super important. Now, another differential diagnosis that you can mention is DDs based on the rapidity of symptoms. right? So if you have a history that is less than 1 month, so the swelling is rapidly increasing in size and it's only been increasing since the last 1 month, then you need to think of aggressive DDs, right? So usually you can have a lymphoma, right? If the age is young, it could be Burkitt's, or if the age is older, it can be a DLBCL. You can have leukemic involvement, right? Like we mentioned earlier, acute lymphoblastic leukemias or lymphoblastic lymphomas can be seen. You can have non-seminomatous germ cell tumors, such as which are aggressive, such as yolk sac tumor or even an embryonal carcinoma. These are known to be aggressive and they grow rapidly. Or you can even have a sarcoma, right? Now, if it is a young patient, it can be a paratesticular RMS. If it is an older patient, you can have other sarcomas. Okay. So that's based on the age. So these are some of the DDs you need to keep in mind, especially if the symptoms are very rapid and the history is less than 1 month or so. Okay. So that is something to keep in mind. Now, let us quickly go through to the classification of germ cell tumor of the testis. Okay. So usually you have two types. Okay. So you have those that are derived from germ cell in situ neoplasia. Okay. So this is divided into, of course, seminoma, right? And you have non-seminoma. Now within non-seminoma, you have yolk sac tumors, right? You have embryonal tumors, and you have teratomas, right? Now, teratomas can be immature, which is malignant, and it can be mature, which is more towards the benign side. And you can have a combination of seminoma and non-seminomatous components, and these are called mixed germ cell tumors, right? And if you have a combination of seminomatous and non-seminomatous, it's usually treated based on the non-seminomatous component, okay? Now, another thing I forgot to mention in non-seminomas is choriocarcinoma, which is another aggressive variant, okay? That comes under non-seminoma. So these are the GCTs that arise from germ cell in situ neoplasia. Now, what about the GCTs of non-germ cell in situ neoplasia origin, right? So you can have a prepubertal yolk sac tumor or a prepubertal teratoma. So these are not derived from the germ cell in situ neoplasia. And you can also have spermatocytic seminomas, right? So spermatocytic seminomas, unlike your regular seminomas, they are much more indolent in nature. And the only treatment, I'll just mention the management quickly, is to do a high inguinal orchidectomy. No adjuvant treatment is required. Okay, right. So that is regarding the classification of germ cell tumors, right? Now, moving on, let us now look at the workup for a germ cell tumor. Okay. So once you suspect a germ cell tumor, the first thing you need to do is a total ultrasound. Based on the histology, you'll have certain findings. So for a seminoma, you will see a hypercoic, right? Homogeneous lesion, right? It will have increased vascularity and it can also have associated microlithiasis. Now, for a non-seminoma, the findings are slightly different. So here it will be heterogeneous in nature. Okay. And you'll also see cystic areas. And you can also see calcifications as well. So this is how you differentiate, get an idea for what type of GCT it is based on the ultrasound findings. Okay. So once you have done that, you will now do your markers. Okay. Now markers, as we all know, you have beta HCG, right? So beta HCG is usually the normal value is less than 5 milli international units per ml. This can vary based on the lab that you use, right? It has a half-life of 24 to 48 hours, right? Now, beta HCG, it's important to note that sometimes it can be spuriously low. So if you have a choriocarcinomatous component and the beta HCG is highly raised, right? Sometimes the test or the testing antibodies can get overwhelmed and the beta HCG value can be falsely low. In that case, if the imaging and the symptoms don't add up with the low beta HCG value, you can repeat it and do further dilution and repeat it by informing your lab, and then you'll find that the beta HCG value is actually very high. Okay, so this is called the prozone phenomenon, where in a high beta HCG, when you test for beta HCG, it can be spuriously low. You can also have a falsely raised beta HCG, right? If the patient is actively taking marijuana, or if the patient has a hypogonadism state. Okay, so those are some points to note regarding beta HCG. Let's move on to the next one, which is alpha fetoprotein, right? Now, the normal value is usually less than 4 to 8 nanogram per ml. Depending on a lab, it might slightly vary. The half-life here is 7 days. Okay, and that is one of the values. And that is one of the markers. And the next one is LDH, right? So LDH, it is more of a marker of the tumor burden, and the half-life is 4 to 5 days. Okay. So now these are the markers that you commonly see. So now, based on the markers, can you get an idea of what sort of GCT it is? So that is something that we can do. So for yolk sac tumors, usually you'll have AFP plus LDH raise. There is no hard and fast rule here, but these are the commonly elevated markers. If you have an embryonal carcinoma, then in that case, usually we get AFP plus beta HCG being raised. And of course, if you have a choriocarcinoma, in that scenario, you will have beta HCG being raised. Okay. Now, an important thing to note here is for a seminoma, AFP is never raised. The moment AFP is raised, despite the histopathology report, you should always consider that there is a non-seminomatous component. So AFP should never be raised in a pure seminoma. Okay. And in seminoma, around 15% of the cases will have rise in the beta HCG. Okay. So that's only seen in 15% of the cases because of secretion by the syncytial trophoblasts. Okay. In majority of the cases, you won't see that rise, but 15% of the cases, you can see a slight rise. And of course, LDH can also be raised. Now, when you come to beta HCG, I'd like to mention one thing. The range is also very important. Okay, so beta HCG can be raised in a variety of scenarios. So usually if it is seminoma, you will see it raised to 100 to 200. Okay, beyond that is slightly rare. So like 15% of the cases, you can see it raised to between 100 to 200. Embryonal, usually it's raised, but it is, between 500 to 1000. Okay, of course, it can go more than that. There's no hard and fast rule, but this is what's commonly seen. And in choriocarcinoma, it is raised between 1,000 and above. So it can go to any value beyond 1,000. Okay, so this is the distribution of beta HCG in various histologies of GCT, right? So once you have done all of this, what is the next step that we go ahead with? So the third thing that we do is to go ahead with the imaging. So usually we go for a CT, abdomen, and pelvis, and you can also put in a CT thorax there. It's not really warranted for seminoma, but this stage we don't have 100% confirmation, so you can do it upfront as well. Okay. Now there is no role for PET CT in staging. Okay, so there's no role for PET CT in staging. That is something that you need to remember, right? And now another point that you need to remember is the role of MRI. So MRI is only done. So MRI of the brain is what we're talking about here. So MRI brain is only done if you have CNS symptoms on presentation. If the beta HCG is highly raised, for example, if it is greater than 50,000, right? Or if you have extensive non-pulmonary visceral mets. So visceral mets or organ mets that apart from the lungs. Okay. So or if you have a significant choriocarcinomatous component. So that's something that you learn after surgery only. But these are the scenarios where you can consider an MRI brain. Okay. Now, let us go to the next step. So once you've done your transscrotal ultrasound, you've done, your tumor markers, and you've done your imaging, right? The next step that you need to take is discuss it in a multidisciplinary tumor board, see if the patient is stable, right? And then we proceed with a high inguinal orchidectomy. So this is something that needs to be done. So now the question might arise, why go for a high inguinal orchidectomy? Why not go for, a transscrotal orchidectomy or a low inguinal orchidectomy that is done at the external iliac ring? We do not do that. We go for a high inguinal orchidectomy because we need negative margins, right? Sometimes the spermatic cord can also be involved. So we need to ensure negative margins with the spermatic cord, right? So to ensure that, we always go for a high inguinal orchidectomy. Then to avoid tumor spillage, right? And another reason is that the testis is a sanctuary site. So being a sanctuary site, chemotherapy's penetration is very less into the testis, right? So that's why we go for a orchidectomy, right? And high inguinal orchidectomy because we need to obtain negative margins with the spermatic cord because there might be spermatic cord involvement and to avoid tumor spillage. So usually if you go for a transscrotal uh, orchidectomy or if you go for any sort of transscrotal procedure like a biopsy, then that results in aberrations in the lymph node drainage and it can spread to the disease rather than spreading to the retroperitoneal nodes, it can spread to the pelvic nodes or the inguinal nodes as well. So any scrotal breach, either in the form of biopsy or an orchidectomy, can lead to aberrant nodal drainage to the pelvic and the inguinal nodes. Okay, so that is something that you need to keep in mind. So at this point, I'd like to talk about indications to omit or to forego high inguinal orchidectomy upfront. So sometimes you might not be able to do an upfront high inguinal orchidectomy and you might have to save it for after chemotherapy. So what are those settings, right? So if you have a very high beta HCG, for example, the beta HCG is raised to greater than 1,000, 10,000, there, doing a high inguinal orchidectomy is dangerous because there's a high chance for bleed as well. Okay. So there you might forego doing it upfront. Then if the patient is highly symptomatic, Okay, so the patient has a lot of symptoms due to systemic spread. You might forego high inguinal orchidectomy upfront and go for chemotherapy instead, and later on do the high inguinal orchidectomy after chemotherapy has been complete. Right. So another reason is diffuse mets. So if you have diffuse, large, bulky liver mets, lung mets, in those scenarios, you might forego doing it upfront and save it for after chemotherapy. So these are some of the scenarios where you might omit doing it upfront and save it for after chemotherapy. Now, another thing that I'd like to talk about here is a contralateral testicular biopsy. Okay. So contralateral testicular biopsy is not something that we commonly do, right? It is only done in very specific scenarios, which is why you might not have commonly encountered this. So indications, what are the indications? So usually we can consider it if you have a young patient, right, less than 40 years of age, and if the testicular volume is very less, it is less than 12 ml. So these two conditions are met, that's an indication. You can do it if there's a significant history of cryptocortism or undescended testis, right? You can do it if the patient has low sperm count in the setting of an atrophic testis. Okay. And you can also do it if there is significant microlithiasis. So that is a risk factor, especially if you have germ cell in situ neoplasia, which in which you will see significant microlithiasis. It is worth considering a contralateral testicular biopsy. Okay, so these are some of the scenarios where you'd consider it, and if you're planning to do it, you cannot do it, directly transcrotally. Like I said, there's a chance for aberrant lymph nodal drainage if you do that. So in this scenario, you use something called the Chevasu's maneuver, right? So this is where you extract the testicles from the scrotum, right? And you bring it above and then take a biopsy and then you put it back there. Okay. So you extract the testis from the scrotum, take the biopsy, and then put it back in place. So this ensures that there's no tumor spillage, there's no transscrotal aberrant lymph nodal drainage, etc. So that's how you do a contralateral testicle biopsy in these scenarios. Now, another thing that you can see is something called a burnt out testis. Okay. So, right. So, a burnt out testis. Now, this is something that is seen where there is spontaneous regression of the primary testicular lesion. Okay. And this is most commonly seen in aggressive disease. So, usually it's seen in choriocarcinoma, where the disease, it grows very rapidly and the primary lesion regresses spontaneously due to the rapid growth, right? Which exceeds the nutritional and blood flow requirements. So the primary burns out, and usually you'll only see the metastatic lesions. Okay. So this is very important because very often you might not get a testicular lesion. You might only get a retroperitoneal node or a mediastinal disease. Okay. So in this scenario, you should always not assume that it's primary retroperitoneal GCT or primary retroperitoneal mediastinal disease. You should always do an ultrasound of the testis to rule out burnt out testis. Because uh, with this scenario, right, if you do an ultrasound scrotum in this scenario, you might see a fibrotic scar, right? Or you might see inflammation, or you might see microlithiasis. And if these features are present, around 50% of the cases will turn out to be a primary testicular malignancy. So if these features are present, you should always go for a high inguinal orchidectomy to confirm it, because the high incidence of a primary testicular lesion that's burnt out being there. right? So in a retroperitoneal mere cell disease, even though it's seemingly primary, you should always do a scrotal ultrasound to rule out a burnt out testis, especially if these features are there. Go for a high inguinal oculoctomy to rule out a primary testicular lesion, because in 50% of the cases, you will get that primary. So that is regarding a burnt out testis. Right. So let us quickly go through the histopathology that you commonly see. I won't get too much into detail here, but what do we commonly see? So for a seminoma, right. So for a seminoma, usually you'll see a fried egg appearance where you'll see large polygonal cells, right, with clear cytoplasm arranged in sheets. So large polygonal cells with clear cytoplasm arranged in sheets separated by fibrous septa. Okay. So you'll see these large polygonal cells with clear cytoplasm arranged in sheets separated by fibrous septa, right? And you'll also see lymphocytes interspersed within the sample. Okay. So that is what you'll commonly see in seminoma. Now, in 10 to 15% of the cases, you can also see syncytial trophoblast as well. Okay. Which is why in 10 to 15% of the cases, you'll have a secretion of beta HCG. Now, for non-seminomatous germ cell tumors, I'll just mention yolk sac tumors here. So here you'll see something called Schiller dual bodies, right? That can be seen. So just something named that you will come across. And in choriocarcinoma, you will see the presence of both cytotrophoblasts and syncytiotrophoblasts. Okay. So just a little bit on the histopathology. Most important is seminoma, right? Now, coming to the IHC, very often we need immunohistochemistry to differentiate, right? So there's something called a pan germ cell marker, which is SAL4. Okay. Now, there are only few conditions where SAL4 is not positive. That is, if it is a spermatocytic seminoma or if it is a prepubertal yolk sac tumor or teratoma. Okay. These are not evolving from the germ cell in situ neoplasia, so they are SAL4 negative. So these are some of the exceptions, but all other germ cell tumors will have a positive SAL4 expression. So if you come to seminoma, usually it will be SAL4 positive, OCT3/4 positive, alkaline phosphatase positive, and CKIT positive. Okay. Now moving on to embryonal. So here you will once again have SAL4 positive, OCT3/4 can be positive, and you'll have other markers such as SOX2, and very importantly, you'll also have CD30 being positive. Okay. Right. Now moving on to yolk sac tumors. So yolk sac tumors, once again, SAL4 is positive. Okay. And you'll also have other markers such as EMA, AFP, right? And glycipan being positive. Okay. And of course, we'll end with choriocarcinoma. In choriocarcinoma, once again, you'll have SAL4 positive and you'll have CK and EMA positive as well. So these are roughly the markers that are positive in various histologies of germ cell tumor. And you can, along with the histopathology, it can give you a clue to the histopathological diagnosis. Of course, the histopathological and IHC is not alone enough. You also go with the serum tumor markers as well. For example, like I mentioned earlier, even if the histopathology in your high inguinal oculoctomy specimen shows a seminoma, if the AFP is raised, you'll automatically assume that it is a non-seminomatous GCT, because AFP should not be raised in a setting of seminoma, right? So the tumor markers also play a role here, right? So now moving on, what is the next step that we take? So the next step that we take is to repeat. So we have looked at the post-op histopathology of the high inguinal oculoctomy specimen. You repeat the tumor markers. Okay. So the tumor markers are usually repeated greater than 4 to 6 weeks after surgery. So you at least wait for, you know, four half-lives to pass before repeating the serum markers, right? And this repeated serum markers post-op is what is taken for staging in the IG-CCC risk stratification, right? So that is used for staging purposes as well. The repeated post-op serum markers greater than 4 weeks after surgery. Okay. So now let us now move on to a very important thing in GCT, which is the staging. Okay. So when we talk about the staging, right? So when we talk about the staging, you can have a PT0 disease, which can usually be a histological scar seen in the testis, usually in a burnt out testis, right? You can have an in situ disease, that is a germ cell in situ neoplasia. You can have a T1 disease. Now, what is T1? It is limited to the testis or the epididymis, right? And there is no LVI, right? And it is not involving the vaginalis, the tunica vaginalis. Okay. Now, moving on, we come to PT2 disease. So this is disease that's confined to the testis or the epididymis with either LVI or involvement of the tunica vaginalis. Okay. And coming to PT3 disease, this includes involvement of the spermatic cord, and PT4 disease is involvement of the scrotum. Okay. So that is regarding T staging. Now coming to N staging, you have N1, N2, and N3. So this deals with the involvement of the retroperitoneal lymph nodes, right? So if you have single or more nodes with the largest being less than or equal to 2 centimeters, it is considered N1. If you have single or more nodes, right, with largest being greater than 2 centimeters, but less than or equal to 5 centimeters, right, and the number of nodes is less than 5, so greater than 2 centimeters or 2 less than or equal to 5 centimeters, and the number of nodes is less than 5, that is considered to be N2 disease. And N3 is if the node size, any of the node, single or multiple, is greater than 5 centimeters, or there is greater than 5 nodes involved. So that is regarding the pathological nodal staging based on the retroperitoneal nodal involvement. Okay. Now, coming to metastatic involvement, you have M1A and M1B. This is very simple. Okay. So you have the presence of non-regional nodes. So nodes extending beyond the retroperitoneum, it comes under M1A, or if you have pulmonary mets. So lung mets comes under M1A, and of course, distant mets, right? So distant non-pulmonary visceral mets. For example, the liver comes under M1B. Okay. So that is regarding the metastatic staging. Now, coming to a very important thing, you also have staging based on the markers. So you have S1, S2, and S3 range. Okay. So let us look at each one of this. So S1 is when the LDH is less than 1.5 times that of the upper normal limit. Or if you have HCG less than 5,000. Or if you have AFP less than 1,000. That is the S1 range. Okay. Before this, you also have something called S0 where the markers are normal. Okay. So now coming to S2, this is when LDH is 1.5 to 10 times that of the upper limit. Or if beta HCG is between 5,000 to 50,000, or if AFP is between 1,000 to 10,000. Okay, so that is the S2 range. Now coming to S3 range, if LDH is greater than 10 times that of the upper limit, it is S3. If the AFP is greater than 10K, it is S3. If the beta HCG is greater than 50K, it is S3. Okay. So if any one of this, so for S2 and S3, if any one is involved, it is S1, S2 or S3. And for S1, all these tumor markers need to be below this level. So I hope you understood the marker staging. Okay. So now that we have established this, we can move on to the next thing, right? So let us stage the disease. So as per AGCC, stage 1 is disease that is confined to the testis. Okay, so I'm just giving a basic overview of the staging. Stage 2 is divided into A, B, and C, right? So stage 1 is confined to the testis with markers in the S0 range. Okay, so that is also important to note. Stage 2A, B, and C is if there is N1 disease, N2 disease, or N3 disease, right? It is considered to be stage 2A, B, and C, right? And here it's important to note that the markers are always in S0 or S1 range. Okay. Now, coming to stage 3, it is divided into A, B, and C. And so stage A is if, right, so stage A is if you have M1A Mets with markers in the S0 or S1 range. So if you have M1A Mets, that is, non-regional nodal disease, or if you have pulmonary Mets with markers in S0, S1 range, that is considered to be stage 3A. So stage 3B is if you have nodal disease or M1A disease, right? So you need to have either nodal or M1A disease, and you should have markers in the S2 range. So it's dependent on the markers, okay? Stage 3B is dependent on the markers. The markers need to be in the S2 range. And of course, stage 3C is if you have M1B disease, that is non-pulmonary visceral mets, or if the markers are in the S3 range. So any one of these criteria is met, you go to stage 3C. Okay, now keeping that in mind, so once you have done the staging, you come to the risk stratification. Now, this is very important because the treatment is based on the risk classification. Okay, so the risk classification is by the IGCC. Okay, and it is important to note that the risk classification is not for stage 1 germ cell tumors, it is for stage 2 and above. Okay, so you do it for stage 2 and above. So for seminoma and non-seminoma, it is slightly different, right? So seminoma, there are only two risk categories. That is, you have good and intermediate risk. There is no poor risk for seminoma. Okay, it has a very good prognosis, so there's no poor risk. Now, for seminoma, there is only one criteria to classify seminomas. Okay, so if you have no non-pulmonary visceral mets, right? If you have no non-pulmonary visceral mets, that is, if you have stage 2 to stage 3A, then you're considered to have good risk seminoma. Now, an important thing to note here is that there is no role for serum markers. There is no role for primary site of the germ cell tumor in risk stratification of seminomas. So this risk stratification is not only for testicular GCTs, it's for mediastinal and retroperitoneal primary GCTs as well. You can use it for all. So in the risk stratification for seminoma, there's no role for serum markers. There's no role for primary site of the testicular for the germ cell tumor. Okay. There's no role for primary site. So only differentiating factors. Good risk is if all disease with no non-pulmonary visceral mets comes under good disease. Okay. So from stage 2 to stage 3A. Now, intermediate disease is presence of pulmonary visceral mets. That is, we're talking about stage 3C. Now, it is very important to note here is that there is no compound called stage 3B in seminoma. Okay, because like I said, the serum markers don't play a role in the risk stratification of seminoma. And like I said, stage 3B is only dependent on the serum markers. So since it doesn't play a role in seminoma, there's no component called stage 3B in seminoma. Okay. So stage 2 to stage 3A with no non-pulmonary visceral mets will automatically come under good risk, and those patients with intermediate risk, that is involvement of visceral mets other than the lungs, will come to stage 3C, and that will come under intermediate risk. Once again, there is no poor risk. Now, for non-seminal germ cell tumors and other, of the testis, retroperitoneal, mediastinum, any site, there are various components involved in the risk stratification. Okay, so number one is the markers. So if you have S1 range of markers, right? Or if you have a gonadal, that is a testicular or retroperitoneal primary, right? So all these criteria should be met, okay, for good risk for non-seminomas, and there is no non-pulmonary visceral mets. So if all these criteria are met, it comes under good risk for a non-seminoma. Okay. Now for intermediate risk, you should have either one of S2 range of markers or S2 range of markers, right? And there should be gonadal or retroperitoneal primary, and there should be uh, absence of non-pulmonary visceral mets. So just make a correction here. All these criteria should be met, okay, to come under intermediate risk for a non-seminoma. Now, non-seminoma also has another category called poor risk, okay? So poor risk is if you have S3 range of markers. So this is anyone. So if anyone is met, it comes under poor risk. So S3 range of markers, if it is a mediastinal primary, so if it's a mediastinal non-seminomatous germ cell tumor primary, it automatically comes under poor risk, okay? Or if there's non-pulmonary visceral mets, it comes under poor risk. So any one of these criteria is met, it comes under poor risk. Now, an important distinction to make here is that a mediastinal, so we're talking about testicular GCTs, but a primary mediastinal seminoma automatically falls under good risk unless there is non-pulmonary visceral mets. Okay. So if there's no non-pulmonary visceral mets, a primary mediastinal seminoma falls under good risk. But unlike a seminoma, a primary mediastinal non-seminoma always falls under poor risk. Okay, so that is an important distinction to make. This is not regarding testicular GCTs, but it's something that you need to know. Right. So now that we have done all the workup and everything, let us now look at right. So we've done the workup, the diagnostic, the staging, as well as the risk stratification. Right. Once you've done all of that, let us look at the workup for treatment. Now, important thing to note here is that this workup shouldn't be done for all stages, but I'm just giving a general overview. If you get a stage, you get a stage 1 to 3, depending on the stage, you might omit some of these workups, but overall, this is what you do. So workup for treatment, what all do we do? Of course, you go for a CBC, RFT, serum electrolytes, right? That is a given. You need to go for a pulmonary function test along with the DLCO, right? Especially if you're giving bleomycin. So that is where the importance comes of a pulmonary function test with the DLCO. Then, of course, if you're giving cisplatin-based therapy, which is a cornerstone of GCT treatment, you have to do a creat clearance. If there's a discrepancy, you might have to go for a DTPS scan. You need to do audiology, right? Baseline audiology needs to be done. And why do we do that? Because cisplatin causes sensorineural hearing loss, right? And of course, a cardiac clearance, especially if the patient has pre-existing cardiac morbidities. So all of this needs to be done for cisplatin. Then super important, because this occurs in young patients, a fertility counseling is always needed with a testicular GCT. Now, you'll also do a baseline serum testosterone and luteinizing hormone as well. Important thing to note here is that around 50 to 60% of all testicular GCTs will have some sort of infertility at baseline. And you should always counsel the patient that with treatment, this fertility can improve. This infertility can improve. So 50 to 60% of the patient's baseline can have infertility, but with treatment, this infertility can improve as well. So these are some of the basic workup that you'll do overall in a case of testicular GCT. You need not do it in all cases, especially, for example, if you're not doing chemotherapy, you can omit a lot of these workups, right? So that is what we do overall, just a basic overview right there. Now, finally, let us get into the treatment. Okay, now coming to the treatment, we'll start off with, right. So we'll start off with the treatment for a stage 1 seminoma. So, like I said, we do not risk stratify based on the IGCCG in a stage 1 seminoma or non-seminoma. Here, we have a separate set of risk factors, right? So, for a stage 1 seminoma, the risk factors are the following, right? So, tumor size is important, greater than 4 centimeters, that is considered to be a risk factor, and also involvement of the retetestis. Invasion of the retetestis is considered to be a risk factor. So these are risk factors for the validated risk factors for stage 1 seminoma, right? So what are the options that you have for a stage 1 seminoma? The most preferred option currently is active surveillance. Okay, so active surveillance is the most preferred option. What is the rationale for active surveillance? Okay, so let us look at, if we have done high inguinal orchidectomy and we do not treat a case of seminoma after that, what is the chance for recurrence, right? So the overall chance for recurrence is around 20%. But what is the chance for recurrence based on risk factors? So the chance is only 6% if there is no risk factor. Okay. And it rises to around 12% if there is one risk factor. For example, involvement of the retetestis, for example. If you have two risk factors, for example, the tumor size is greater than 4 centimeters and there's involvement of the retetestis, the chance is around 30%, right? This is based on the risk factors. This is overall. So in active surveillance, the basic rationale here is that even if you don't treat the patients post high inguinal orchidectomy, a stage 1 seminoma, if you have no risk factors or one risk factor, the chance for recurrence is very low. It is around 6 to 12%, right? And important thing to note here is that 99% of the relapses, even if it relapses, it's around 6 to 12%. Even if it relapses, 99% of the relapses are coming in the good risk category. So they can be salvaged effectively. Okay. So that's around 99% of the recurrences, if they do recur, right? And the recurrences usually occur around 90%, if they occur within the first 3 years. So the basic funda is that you can avoid the toxicity, the long-term toxicity, especially because these patients are long-term survivors. You can avoid the long-term toxicity, for example, cardiotoxicity, metabolic syndrome with chemotherapy, lung-related toxicity, especially if you're giving bleomycin, radiation-induced toxicities, such as secondary malignancies. All of this can be avoided by going for active surveillance. And even if they recur, the chance for recurrence is low. Even if they recur, 99% of the recurrences are coming under good risk. Okay. And the intensity of active surveillance should be in the first 2 to 3 years, because that's when you have the highest chance for recurrence. Okay. So those are some of the pros. You can avoid the toxicity, the long-term toxicity of treatment. What are some of the cons, right? So the cons include cost, logistical constraints, especially if you're in a population where follow-up is very difficult, there it might be not that possible to implement active surveillance. Also, there's patient anxiety and there's compliance issues as well. Okay. So that is regarding the pros and cons and the rational of active surveillance. Now coming to the protocol. So you have based on various guidelines, you have various protocols. So usual protocol would be initially. What you tend to do is you'll do a CT, abdomen plus pelvis, right? Plus or minus markers. In seminoma, only the beta CG is raised in stage one, could be raised. So markers are not always necessary, right? Uh, there's no role for chest imaging unless clinically indicated. So you would do this initially 4 monthly. So I'm just giving you an example of active surveillance for year one and two, and then you do it 6 monthly for year three. And like I said, after the third year, the chances for recurrence decreases drastically. So then you'll do annual follow-up for year four and five. Okay, so that is a typical active surveillance protocol for seminoma. Now, what are the other options that you have? Especially if you have one or two risk factors, or if the patient is not compliant or not willing for active surveillance, there you can go for adjuvant carboplatin. So that is another option. Give adjuvant carboplatin, right? It is given at an AUC, area under curve, 7 for a single dose. Okay. There is also some data if you have two risk factors or more to give 2 doses of AUC7 carboplatin. That is also there. But traditionally, we give carboplatin AUC7 single dose. That is one treatment modality. So the question arises, what is the advantage of single agent carboplatin? Right? You usually give it if there's risk factors or if there's poor compliance to active surveillance, right? So what is if the patient is not willing for active surveillance? So what is the advantage of giving carboplatin over, say, adjuvant radiation, right, which is the third modality? So here, there is a decreased risk for secondary malignancies, which is notorious with radiation. Okay. And you can also decrease the rates of contralateral GCT because this is, a systemic modality. So you can decrease the rates of contralateral GCT. Also, there's decreased, rates of, right. So there's also decreased rates of infertility. So RT can have, higher risk for infertility, whereas with adjuvant carboplatin, it's less. So that's why adjuvant carboplatin currently, if you're giving treatment in this day and age, right, if you have one or two risk factors, or if the patient is not willing for active surveillance or is non-compliant, is likely to be non-compliant, then you'd go for adjuvant carboplatin rather than adjuvant radiation, which we'll just talk about in a second, because of these advantages: less chance for long-term toxicities, and also slight decrease in the contralateral GCT as well. Now, the third option is adjuvant RT. Okay. Now, adjuvant RT, usually it is given with a para-aortic field. Okay. So the para-aortic field extends. So the superior margin is the T11, T12 vertebral junction. The lateral margins are the transverse process of the vertebrae, and the lower margin is the L5 S1 junction. Okay, so a para-aortic field is given, and you give, anterior as well as posterior fields, and you treat to a dose of 20 gray in 10 fractions. Okay, 20 gray in 10 fractions. So that is adjuvant radiation. Like I mentioned before, we have various cons, such as secondary malignancy, right? Infertility. And you can also have cardiovascular effects. So because of all this, in this day and age, if you're treating a stage 1 seminoma, you would give adjuvant chemotherapy rather than adjuvant RT. Back in the day, adjuvant RT was the way to go, but it's been superseded by active surveillance and adjuvant carboplatin. Okay. Now, the important thing to note here is that the disease-specific survival, regardless of whether you go for adjuvant RT or adjuvant chemotherapy or active surveillance, is 98 to 99%. So the survival is, almost close to 100% regardless of the modality. But there are certain pros and cons to keep in mind with each modality, like I mentioned before, right? So that is regarding the management of stage 1 seminoma. Now let us look at stage 1 non-seminoma. So even if you have a seminomatous and non-seminomatous mixed component, you'll always treat like a non-seminoma. Okay. So what are the options here? So here also you can go for active surveillance, okay, or you can go for a single cycle of BEP into one cycle. So BEP is bleomycin, topoisomerase and cisplatin. We'll get into that in detail later on. And of course, you can also go for retroperitoneal lymph node dissection. Okay. So these are the three modalities. Now, before we get into each one of them, let us look at the risk factors for a stage 1 non-seminoma. So the risk factors include LVI. So this is the main validated risk factor. Lymphovascular invasion is the main validated risk factor. Other risk factors include embryonal carcinoma, right? Uh, or if there is spermatic cord involvement or scrotal involvement. The main validated one is LVI. The other risk factors that you can take into consideration are embryonal carcinoma component or T3, T4 disease. Okay. So now let us go into each of these modalities. Active surveillance. Active surveillance should always be taken with a pinch of salt in non-seminomatous germ cell tumors. The reason being is that if you have no risk factors, this is a modality that you can consider. So here, with no risk factors, the chance for recurrence is around 30%. So around 70% of the patients need not get any treatment, right? So that is why you can go ahead with this. And even if, just like in seminoma, even if they relapse, even if that 30% relapse, they relapse as good risk and they can be salvaged effectively with chemotherapy. So active surveillance in non-seminomatous germ cell tumors should only be done if there's no risk factors, because if you have a single risk factor, so one risk factor is like LVI, then the chance for recurrence goes up to 50%. So this becomes slightly unacceptable. So in this scenario, you would not do active surveillance. Okay. So for no risk factors, that's where you do it. Chance for recurrence there is 30%. Majority of the recurrences are good risk and they can be salvaged effectively. Right. Now here the surveillance is with a CT. So you'd also consider CT thorax, abdomen, pelvis. So thorax is also included here. And you can also add serum markers here. Okay. Unlike for your seminoma. So we already spoke about the frequency of active surveillance, etc. It varies from guideline to guideline, but you'd usually do it if there are no risk factors. So if you do have a risk factor, what are the options, right? So the option is to give a single cycle of BEP. So this is preferred if you have uh, one risk factor, such as involvement of lymphovascular invasion, right? You can also give BP over RPLND. I mentioned that RPLND is another sort of modality. RPLND is another sort of modality, uh, you know, it's a third modality for management of non-seminomatous stage 1 disease, right? So RPLND will not be preferred, especially if you have an embryonal component, okay? Because embryonal disease, like I said, can skip the retroperitoneal lymph node and spread directly to the lungs. So in that scenario, you would rather go for one cycle of BEP, okay? Or if you have a single risk factor, uh, such as lymphovascular invasion, you go for one cycle BEP, okay? So that is another option. We'll get into the BEP regimen later on. Now, the third option is retroperitoneal lymph node dissection, right? So, like I said, the most common site of spread is the retroperitoneal lymph nodes, and that is why RPLND comes, you know, up over here. So, RPLND is usually done if there is one risk factor or more, right? So, if there's lymphovascular invasion, RPLND is usually done. Now, usually for embryonal carcinoma, you'll try to avoid RPLND because, like I said, it can bypass the retroperitoneal lymph nodes and spread directly to the lungs. Okay. So no risk factors, active surveillance is an option. If the patient is not compliant to active, is not willing to be compliant to active surveillance, or if there's one risk factor such as lymphovascular invasion, then you would go for BP or RP-LND. Now, between both these, BP is preferred currently because BP can work in embryonal carcinoma as well, and it's also got good decrease in recurrence rates for when there is lymphovascular invasion. RPLND is not currently preferred, especially in embryonal carcinoma risk factor being present, because uh, like I said, embryonal carcinoma can bypass the retroperitoneal lymph nodes and go directly to the lungs. Another reason is that RPLND has side effects of retrograde ejaculation and other side effects, which can cause, which is a long-term side effect that is, not preferred for the patient, right? So that's why you would tend to prefer one cycle of BP or RPLND. Okay. Now, RPLND, I'll quickly just mention the two types. So you have a template-based dissection or a nerve sparing RPLND. So template sparing dissection, one thing to note here is that, so this is based on a template. So it helps the surgeon avoid regions where chance of metastasis is less. So based on the side of the testis that's involved, the extent of the disease, you can selectively do an RPLND, a template-based retroperitoneal lymph node dissection. Okay, so that is not that commonly done. Usually, what we do is a nerve-sparing bilateral retroperitoneal lymph node dissection. Okay, and nerve sparing is important because it preserves the sympathetic chain of postganglionic nerves, right, including nerves in the hypogastric plexus as well, which is required for normal ejaculation. So you're decreasing the risk for retrograde ejaculation, which is a high cause for infertility with RPLND. Okay. So, like I said, RPLND, because of the slight risk for retrograde ejaculation, although it's very less with nerve sparing bilateral RPLND, and because it is not as effective in embryonal carcinomas, BP one cycle is preferred. But it can also be given, it is also still a valid modality. Okay, so that is the management of stage 1 non-seminomatous germ cell tumor. So now moving on to the management of stage 2 and stage 3 GCTs, right? So let us now get into the management of the remaining stages of GCTs. So if you have done your imaging, right, and if there's involvement of the retroperitoneal lymph nodes or distant sites, in that scenario, you will need further management in the form of chemotherapy, which is now the standard of care. So for stage 1 and seminoma, non-seminoma, we've discussed the management options. So it is different for stage 2 and 3 GCTs, where you need to give chemotherapy. Okay. So there are some exceptions to chemotherapy here. Let us look at some of those exceptions. Okay, so we'll start off with the management of stage 2 and above. Right? So the management of stage 2 and above GCT is based on the IGCCG, IGCCG risk stratification, right? Now, when it comes to a seminoma or a non-seminoma, that falls under good risk, what is the management? Okay, so when you have a good risk GCT, the management is either 3 cycles of BP or 4 cycles of EP. Now, what comes under a good risk GCT, right? Now, when you're talking about a seminoma, this includes all the stages, like I discussed earlier, from stage 2 to stage 3A. Okay. There is no stage 3B as such for seminoma because that is based purely on the serum markers, which is not a important factor when it comes to seminomas, right? And for non-seminomas, once again, it is stage 2 to stage 3A. Okay. Now, like I mentioned, the treatment of choice here is 3 cycles of BEP or 4 cycles of EP. Now, if possible, what would you prefer? You'll always prefer 3 cycles of BEP because this is based on a phase 3 trial which showed that there was a disease-free survival benefit to giving 3 cycles of BEP over 4 cycles of EP. But the overall survival between giving 3 cycles of BP and 4 cycles of EP was the same. So based on the fact that the overall survival is the same, you can give both, but you'd always prefer giving 3 cycles of BP over 4 cycles of EP, right? If bleomycin, if there's any contraindication to bleomycin, in that scenario only you can consider 4 cycles of EP because this overall survival is better. But wherever possible, give 3 cycles of BP because the disease-free survival was better. Now, there are some exceptions to this. When you look at a seminoma, that is stage 2A, right? Or stage 2B, and the retroperitoneal lymph nodes. So stage 2A and 2B means there's involvement of the retroperitoneal lymph nodes. So if you have stage 2B, that is less than 3 centimeters, or stage 2A, in that scenario, another alternative option to giving chemotherapy is to give radiation. Now, of course, that is not preferred nowadays, right? Because we spoke about all the cons of giving RT, the secondary malignancies, secondary malignancies, infertility, cardiotoxicity, etc. Okay, so that is why we avoid RT, but this is another option, maybe for patients who are not fit for chemotherapy or have contraindications to giving chemotherapy, right? So in that scenario, you can consider radiation. But in this scenario, you would not give the paraaortic field, you will give something called the dogleg field, right? Or hockey stick field. So that is what you would give. Just quickly go over what that field is. So it starts off from T10 to 11, T11 junction, right? That is superior margin. The lateral margins, once again, is the transverse process of the vertebrae, right? And then, so what you do is around the midpoint of L4, the midpoint of L4 vertebrae, you will then lateralize the field to the top of the superior aspect of the acetabulum. Okay. So superior margins T10, T11 junction, lateral margins are the transverse process of the vertebrae. And at the midpoint of the L4 vertebrae, you lateralize the field to the ipsilateral uh, uh, to the side of the testis that is involved up till the upper border of the acetabulum. Earlier, it was the superior aspect of the obturator foramen, but that has been modified to the upper aspect of the acetabulum. Okay. So this covers the retroperitoneal nodes as well as the pelvic nodes. Okay. So a classic dogleg, modified dogleg field or modified hockey stick field up to the upper border of the acetabulum is what is another alternative option for those patients who are not fit for chemotherapy. Otherwise, we currently do not use this radiation because of all the toxicities, long-term toxicities that I spoke about earlier. So that is an other sort of an exception, that an alternative to giving chemotherapy, right, in good risk. Now, in non-seminoma, there's another alternative for patients who have, right. So for patients who have stage 2A disease, you can also consider doing, right. So for 2A with serum markers in the S0 range. Okay, so 2A with serum markers in the S0 range, there you can consider doing, after high inguinal orchidectomy, you can do RPLND alone. Okay, so you can, rather than going for chemotherapy, you can consider doing RPLND alone. And this is contraindicated in certain settings. So this is an option only if there is no elevated tumor marker. So S0 range post-op tumor markers. There's no back pain. Okay, so this is what the trial showed. The trial for RPLND in stage 2A S0. There should be no back pain. There should be no node size greater than 2 centimeters. That is, should be stage 2A disease, right? And there should not be so no embryonal predominance, because we know that embryonal carcinoma can bypass the retropetal nodes. Okay, no embryonal predominance. So in that scenario, you can consider doing an RPLND, right? Upfront RPLND in stage 2A S0 with no back pain, with no nodes greater than 2 centimeters and no embryonal predominance, right? So that is another option there that you can consider doing. So that is regarding the management of good risk GCT. 3 cycles of BP or 4 cycles of EP. 3 cycles of BP are always preferred. For seminoma, an alternative is for stage 2 and stage 2B less than 3 centimeters. You can give a modified dogleg or hockey stick field radiation. And for non-seminoma, for stage 2A S0, you can also consider doing primary RPLND. Okay, so these are some other alternative options. Of course, if in the RPLND there is node positivity, you might have to consolidate, right? So if it's N2 node, you might have to give 2 cycles of EP. And if it's N2 or N3 disease, you might have to give 3 cycles of BP. Okay, so these are the treatment options. So uh, I'd just like to draw your attention to it again. Non-seminoma stage 2A S0 with no back pain, no nodes greater than 2 centimeters, no embryonal predominant component. You can do a primary RPLNT as an alternative. If it's N1 PN1 disease, pathologically N1 disease, you can give 2 cycles of EP. If it's pathologically N2 or N3 disease, you'll have to consolidate with 3 cycles of BP. Okay, so that is regarding the management of your good risk disease. Now, let us look at the management of intermediate risk disease. So, when we talk about intermediate risk, this includes for seminoma, it includes stage 3C disease. And for non seminoma, it includes stage 3B disease. That is, if, like I mentioned earlier, if there's a primary retropetal or primary testicular malignancy with no non-pulmonary visceral mets, but with S2 range of markers, that comes under intermediate risk, right? So for these cases, what do we do? So the treatment of choice here is to give 4 cycles of BP. Unlike good risk, you have to give 4 cycles of BP. Okay. So 4 cycles of BP is the standard of care. And for if there's any contraindications, like we'll talk about later, to bleomycin, you can also give 4 cycles of VIP. So VIP stands, V is VP16, which is a toposide, ifosfamide, and platinum, which is cisplatin. Okay, so that is the treatment of choice there. Now, coming to poor risk. Poor risk is only non-seminoma stage 3C, right? So for poor risk non-seminoma stage 3C, once again, the treatment is exactly the same. 4 cycles of BP, or if there's contraindications to bleomycin, 4 cycles of VIP. Okay. So I hope you understood the treatment there. Now let us get into these regimens. Okay. Let us get into these regimens over here very quickly. Now, before we get into the regimens, between BEP and VIP, you will always prefer BEP. The reason for that is the hematological toxicity, right? When we compared VIP and BEP, there was no difference in DFS or OS, but the hematological toxicity was significantly higher with the VIP regimen. So that's why you would tend to avoid VIP and give BEP always, unless there's a contraindication to bleomycin for both intermediate and poor risk GCT. Okay, right. So now let us look at how to go about giving chemotherapy. So first we'll start off with the BP regimen, right? So the BP regimen consists of injection bleomycin. And bleomycin is given at a dose of 30 units, day 1, 8, and 15. And you also give injection etoposide, which is given at a dose of 100 milligram per meter square IV, day 1 to 5. And you also have injection cisplatin, which is given at a dose of 20 milligram per meter square IV, day 1 to 5. And this is repeated every 3 weeks. Okay, so this is the BEP regimen. Now, if you're giving EP, it's the same regimen, same dose, same duration, but you'll only give etoposide and cisplatin. Okay, so that is regarding the BEP and EP regimen. Now, what are some of the things that you need to take care of or remember while giving these regimens, right? So the various things that are important here while you're giving these regimens. Okay, so let us quickly look at that. So first of all, we start off with bleomycin. So when you give bleomycin, important thing to note here is that there is a high risk for skin toxicities as well as lung toxicities in the form of pneumonitis and ILD. The reason for that is the metabolizing enzyme for bleomycin, that is bleomycin hydrolase, is deficient in both these organs, that is the skin and lungs, which is why there's a high susceptibility for skin and lung toxicities. Okay, so uh, what are the contraindications for bleomycin? Okay, so the absolute contraindication, first of all, is a DLCO less than 30 percentage. Okay, the relative contraindications, there are many. So relative contraindications include age greater than 40 years, right? If there is impaired kidney function, so creat clearance is less than 80 ml per minute, right? If there is history of smoking, right? If there's history of lung pathology, for example, COPD or pre-existing ILD, there you can omit it. If there's you know a high chance for right, if there's a high chance for GCSF requirements, so for example, the patient has multiple comorbidities or the patient's general condition is poor and they might require GCSF, right? In that case, so might require GCSF. In that case, you can omit bleomycin. And of course, where thoracic surgery is, it is expected. For example, if you have multiple large, bulky lung mets, or if you're treating a primary mediastinal non-seminomatous germ cell tumor, where you might need to do thoracic surgery after chemotherapy, there you can consider VIP over giving bleomycin-based regimen, right? So planned thoracic surgery. Okay. So these are some of the relative contraindications and absolute contraindications. One more thing, a couple of more things under relative contraindication is DLCO, that is borderline, that is between 30 to 60 percentage. And also if the cumulative exposure is between 360 to 400 units of bleomycin. So for example, if the patient has already been treated with for a prior Hodgkin's disease in their childhood and they've already been exposed to bleomycin, so if the cumulative dose is approaching more than 360 to 400, then you might go for a non-bleomycin based regimen. Okay, so that is regarding bleomycin and the absolute and relative contraindications. Of course, if there is a absolute or relative contraindication, if it is good risk, we go for 4 cycles of EP. If it is an intermediate or poor risk, we go for VIP over BP regimen, right? Okay, now moving on, we'll move on to cisplatin. What are some of the things that you need to watch out for when giving cisplatin? Of course, like we all know, Cisplatin has revolutionized the treatment of germ cell tumors because it improved the survival significantly. Okay, there's a huge jump in the survival by the introduction with the introduction of cisplatin. That's based on that it reached that curative status. Okay, so that was introduced. Cisplatin in germ cell tumors was introduced by a scientist called Lawrence Einhorn, right, in 1974. It's a landmark introduction of cisplatin into the treatment of GCTs, which shot up the curative rates. Okay. Now, another important point to note is why. Why does it work so well in GCT? It is because of a couple of reasons. GCT has a high expression of OCT2 transporters. This OCT2 transporter is the main transporter that transports cisplatin into the tumor cell. Because it is present in a high degree in germ cell tumor, germ cell tumors have a high intrinsic sensitivity to cisplatin. Also, because of high expression of HMG box genes. These HMG box genes, what they do is they stabilize the DNA damage caused by cisplatin. So they prevent repair of the DNA damage caused by cisplatin. So because of this high prevalence, it enhances the sensitivity of cisplatin, right? So those are the two reasons why germ cell tumors are highly sensitive to cisplatin. Okay, I hope you understood that. And of course, what you need to note here is that you need to give hydration, right? Since you're giving a lower dose of 20 milligram per meter square, you can get away with 1 liter of hydration, although some institutes still give 2 liters of hydration with normal saline. And of course, you need level 4 anti-emetic cover. It's very important. Okay. So those are some of the things that you need to note because nephrotoxicity is very commonly seen. It can be seen if you do not maintain your hydration protocol. And of course, it's got a high risk for nausea and vomiting. So level 4 antiemetic cover needs to be given. And we do a baseline audiometry to rule out baseline sensory hearing loss, etc. Now, coming to etoposide. Now, etoposide side effects basically is you should an important point to note is you should always give the infusion greater than 30 to 45 minutes. Otherwise, it can cause hypotension in patients. Okay, so that's something that they commonly ask and something that you should remember. Another important thing, relevance of etoposide to germ cell tumors is that the cumulative dose is very important. So if the patient has been exposed to a cumulative dose of greater than 2 gram per meter square of cisplatin, there is a greater than 5 to 6% risk of developing acute leukemias, most commonly AML. So the patient has previously been treated with etoposide. You need to keep that risk of developing AML in mind because they would have exceeded that 2 gram per meter square cumulative dose. Okay, so that is regarding these three drugs that are used as part of the BEP regimen. Another important point to note is that the risk for febrile neutropenia is 10 to 20 percentage with the BP regimen. So usually we give secondary prophylaxis with growth factors. So we do not give it with the first cycle right away. We look for development of neutropenia and then only we add growth factors and subsequently with each cycle. So it is called secondary prophylaxis. Okay. So that is something that has to be noted. So this is regarding the BEP regimen. Let's quickly look at the VIP regimen as well. So it's given as an alternative in intermediate and poor risk, especially if there's, relative or absolute contraindications to bleomycin. Like I said, it causes high myelosuppression. Okay. So this consists of injection etoposide, 75 milligram per meter square, IV day 1 to 5, and injection ifosfamide, 1.2 gram per meter square, IV day 1 to 5, and injection cisplatin, 20 milligram per meter square, IV day 1 to 5. And this is given every 3 weeks. Okay. And of course, because you're giving ifosfamide, there's a high risk for hemorrhagic cystitis. So you always add mesna. And mesna is also given at a dose of 1.2 gram per meter square. And this is divided over at the start of chemotherapy, at 4 hours, and at 8 hours. Okay. This is also given IV day 1 to 5. So, what are some of the important things that you need to note with the VIP regimen? We already spoke about the quirks of etoposide and cisplatin. When it comes to ifosfamide, once again, you always give mesna because acrolein is a byproduct which can cause hemorrhagic cystitis. Of course, the hydration of cisplatin also takes care of that risk for hemorrhagic cystitis as well. So that is also there. It is inbuilt into the regimen, and you always give mesna, right? And ifosfamide can also cause neurotoxicity due to chloroacetaldehyde metabolite. So always look out for neurotoxicity. If there is neurotoxicity, you need to give methylene blue treatment with methylene blue 50 milligram given every 6 to 8 hours till the neurotoxicity subsides. And following that, you cannot re-challenge with ifosfamide. Okay, so there's a couple of quirks regarding the VIP regimen, and here the risk for febrile neutropenia is greater than 20 percentage. Because it is greater than 20 percentage, you should always give primary prophylaxis with growth factors. Okay, so that is the difference. Okay, so I hope you understood all of that. Now we come to another point that we need to note. What do we monitor before each cycle? So before each cycle, you should always, you know, once again take a history, look for any toxicities of chemotherapy. Physical examination should be done, including the lungs, the skin, right? You need to look for a single breath count test, look at the SpO2, look at the chest, look at the respiratory rate, make sure there's no lung toxicity for bleomycin, right? Uh, then, of course, you need to do a CBC, right? Look for myelosuppression, renal function tests, platinum-based toxicity, or ifosfamide-based toxicity, and serum electrolytes as well, okay? Which can also be deranged with cisplatin. And you'll also repeat the serum markers prior to each cycle. Now, what sort of decrease do you expect in the serum markers with every cycle? So you expect a log decrease. So greater than 10x times decrease is what you expect with each cycle. But if you do not attain a log decrease, that is not grounds to change the treatment. Okay. So any decrease, even if it is by one, you should not change the treatment. You should go ahead with treatment. Okay, with the same protocol. So log decrease is what you ideally expect, but if there's any decrease, you still continue with the same protocol. Only if there's increase, you consider switching treatment. Okay, which is very rarely seen. And of course, if you're giving bleomycin-based treatment prior to every cycle, you should also do a PFT with DLCO, right? If there is a greater than 20 percentage decrease in the DLCO with one cycle, with each cycle, then you should consider omitting bleomycin or changing over to VIP, right? Because greater than 20% decrease is associated with a higher risk of pneumonitis. So that is a clinician-based decision based on the decrease in DLCO with each cycle, okay? Regarding omitting or replacing bleomycin. Okay, so that is the monitoring that you'll do before each cycle, okay? So let us quickly go through a couple of scenarios. What if you have brain metastasis? So if you have brain mets, usually what do we do? Okay. So if you have brain metastasis, usually what we do is after hyoguanal orchidectomy, if it is possible, uh, or you can even omit hyoguanal orchidectomy and save it for later after systemic therapy. But regardless, if you have upfront brain metastasis, right, you look at whether there's any herniation or bleeding. If there's any impending herniation or bleeding, you might go for surgery. Okay. to prevent, because impending herniation or bleeding is associated with high mortality, so it's better to go for surgery if possible. Okay. Otherwise, if the patient is not a candidate for surgery or does not have impending herniation or bleeding, there you can go for SRS, stereotactic radiosurgery, or WBRT. So that will depend on the number of brain mets, the location, etc. Right, and along with this, you will give a prephase EP. Okay, so here you will give cisplatin 20 milligram per meter square day 1 to 3, and etoposide 100 milligram per meter square day 1 to 3 only. This can also be done up for 2 days only. Okay, and this can be repeated weekly. Okay, to tide over the RT period or to tide over the period where the patient is extremely symptomatic. So that is how you treat a patient with upfront brain metastasis. So this is upfront. Now, what if the patient develops brain mets during treatment? So during treatment, if you've done an MRI and the patient has developed brain mets, then you will assess the systemic disease. So you do a CT, right? You will see if first of all, you'll see if the serum markers are not increasing. So if it's not increasing, and if you've done a CT of the extracranial site, so CT thorax, abdomen, pelvis, and there's response in the extracranial sites, and there's only progression in the brain. If there's only progression in the brain with no extracranial progression and no increase in serum markers, then you can continue the same treatment. Same systemic treatment, and give local treatment to the brain. So this is in the scenario if there's no extracranial progression and there's no increase in serum markers. But if you have brain mets developing during treatment and there's extracranial progression and also there's increase in serum markers, then you need to give another line of therapy. You cannot continue with the same line of therapy. But if there is no extracranial progression, if there's no increase in serum markers, then you can treat the brain mets separately with local treatment. You can interrupt the systemic therapy, treat with local treatment, then continue the same systemic therapy. Okay, so I hope you understood that. And one interesting point here is that if the patient develops symptoms of brain mets, such as headache, nausea, vomiting, altered sensorium, seizures, you need to rule out other causes for those symptoms. For example, altered sensorium can also occur due to, altered electrolytes, right? Due to giving cisplatin, right? It can also occur, so for example, hyponatremia can also cause altered sensorium. It can also occur due to cerebral venous thrombosis or stroke, which is a rare side effect of cisplatin. So this is in you know a point for those who want to be toppers. Cerebral CVT and stroke can also occur due to, as a rare complication of cisplatin, that can also cause altered sensorium. So when you're searching for brain mets due to development of CNS-like symptoms during treatment, always rule out these other causes due to treatment. Okay, so that is management of brain mets upfront and during treatment. I hope you understood that. Right. Now, another scenario is prephase. So suppose the patient is sick, okay? The patient has high beta HCG. The patient is highly symptomatic for visceral mets, or the patient has upfront brain mets that is symptomatic. Then you won't give the definitive chemotherapy right away. You'll give a prephase with EP. I already mentioned it earlier in the brain met section. You'll give cisplatin 20 milligram per meter square day 1 to 2 or 3, and etoposide 100 milligram per meter square day 1 to 2 or 3, and you can repeat this every week till the patient is symptomatically better to take the definitive chemotherapy. So prephase comes in those settings. So that is something to remember as well. Okay, so now we have done the treatment and we come to a very important junction, which is the post-treatment evaluation. Okay, now the post-treatment evaluation is slightly different. It is slightly different for seminomas and non-seminomas. So let us quickly look at that. So now we're going to talk about the post-treatment evaluation. Okay. So once you've done the treatment, the post-treatment evaluation is slightly different for seminomas and non-seminomas. So we'll talk about seminoma first, right? So once we have done the treatment, you repeat the markers at 6 weeks. Okay. So you repeat the tumor markers at 6 weeks. If the markers are normal, you go to the next step. Okay. If the markers are not normal, then you have to evaluate further and give second line treatment. Now, if the markers are normal, then you do a CT, thorax, abdomen, and pelvis. Okay. And within the CT, thorax, abdomen, pelvis, if all the tumor sites are less than 3 centimeters, you keep the patient on follow up. Okay. Now, within the CT, thorax, abdomen, pelvis, if the tumor size at any site is greater than 3 centimeters, there is a high risk for residual disease. And in that case, you do a PET CT. So this is based on a trial called the SEMPET trial, which showed that in seminomas post-treatment, PET CT has a 80% sensitivity, 100% specificity, and a 96% negative predictive value. So it is highly specific and it has a high negative predictive value. So because of that, you can use PET CT whenever there's a residual tumor site at of size greater than 3 centimeter. Okay, so any site with size greater than 3 centimeters, you can do a PET CT, and in that PET CT, you can have various scenarios. So if the PET is negative, then you can keep the patient on follow up. Okay. Now, if the pet is equivocal, for example, if you have a SUV max of 2 to 3, it is slightly borderline, right? So you can consider doing a repeat pet after 2 to 3 months. And if that is negative, you can keep the patient on follow up. Okay. Now, if the pet is positive, right? If there's definitive FDG uptake, what do you do in that scenario? Okay, so we'll just talk about that. So if the pet is positive, what we tend to do is we can resect the residual disease. Although in a seminoma, because of the extensive post-treatment desmoplastic reaction, because there's a lot of fibrosis, it might be difficult to resect. In that case, you can take a biopsy from the PET avid site. Okay. So now, this is what you do. Ideally, you should resect the lesion. Okay. Right. So once you have done that, right, once you have resected the lesion, there are various scenarios. Okay. So once you have resected the lesion, if there is residual disease, you look at the percentage of residual disease. So the percentage of residual disease is less than 10% of the resected mass. Then what you do is you can go for follow-up. You need not give adjuvant chemotherapy. If the percentage of residual disease is greater than 10%, then you should consolidate with either 2 cycles of EP or 2 cycles of VIP or 2 cycles of TIP. Okay, TIP is paclitaxel, ifosfamide, and cisplatin. Okay, so if there's residual disease greater than 10% in the resected specimen, you should go for consolidative chemotherapy. Now, if there is no residual disease, in that scenario, you can keep the patient on follow-up. So that is regarding the post-treatment management of seminomas. Okay, I hope you understood all the scenarios. This is a flowchart that you can use to guide your post-treatment management. Okay, now if resection is not possible, right, and the biopsy is positive, then you need to go for a second line treatment. Okay. Biopsy is positive, resection is not possible. If the biopsy is negative, you can consider keeping the patient on close follow-up. Okay. So that is regarding when you cannot go for resection and only biopsy is possible. Okay. So that is regarding post-treatment management of seminomas. Now let us come to the post-treatment management evaluation of non-seminomas. Okay. So here once again, at 6 weeks, we look at the tumor markers, right? And if they are normal, then you proceed further. If they are not normal, you evaluate for next line of treatment. So if they are normal, what do we do? Then you do a CT, thorax, abdomen, and pelvis. Okay. Now here, it is very important to note that in the CT, thorax, abdomen, pelvis, you look at the size of the lesion. So there's no role for PET-CT in the post-treatment evaluation of a non-seminoma. In the CT, thorax, abdomen, and pelvis, you look at the size of the lesion. Okay. So if the size of the lesion is less than 1 centimeter, you can keep the patient on follow-up. Anything greater than 1 centimeter or more should be resected. Okay, because there's a significant risk for residual disease. Okay, so ideally it should be resected. Okay, now, so resection, what all can it involve? So very commonly you'll have residual retroperitoneal lymph node. So you'll go for bilateral retroperitoneal nerve sparing retroperitoneal lymph node dissection. Okay, plus or minus resection of other sites. So if you have any liver disease with normal markers that is greater than 1 centimeter, so you'll resect those liver lesions, residual liver lesions. If you have lung lesions, you'll go for a wedge resection of the residual lung lesions. Okay, and once you've resected the disease, then what is the next step? Okay, so once you've resected the disease, very commonly, what you see is that 15% of the cases have residual disease. Okay, 15% of the patients have residual disease. In that case, you need to consolidate with chemotherapy, either 2 cycles EP, 2 cycles VIP, or 2 cycles TIP. Okay, so consolidation is required. And in 45% of the patients, you will have fibrous tissue. Okay, and if you have that, you can keep the patient on follow-up. And in 40% of the patients, you will have a teratoma. Okay. In that case, also you can keep the patient on follow-up. Now, it is very important to resect the disease because you can either have a residual disease in 15% of the cases, which you need to take care of and consolidate with further chemotherapy, or you can have a teratoma. Now, teratoma is very important because if you leave that teratoma, it can grow. It's called the growing teratoma syndrome. And that growing teratoma syndrome can cause local symptoms, right? It can cause progression, and later on, it might even be unresectable. And the most important complication is it might convert to a malignant form. So there can be malignant transformation. It can transform into a peanut. It can transform into a rhabdomyosarcoma, etc. So that can cause even more headaches. So you always resect the residual disease greater than 1 centimeter. Okay, so that is always done in case of non-seminoma. Now, resection is not possible. In that scenario, if the markers are negative, you can keep the patient on close follow-up or give second-line treatment. But of course, close follow-up is what you'd prefer if it is not resectable. Okay. So that is regarding the post-treatment evaluation and management of non-seminoma. Okay. So that both seminoma and non-seminoma post-treatment evaluation is super important to know. Okay. So I hope you understood that. Now, moving on. Suppose the patient has, okay, so suppose the patient has, right. So once you've done your evaluation, and done what is necessary, you keep the patient on follow-up with imaging as well as serum markers on routine basis based on the guidelines that you're following. So NCC and ESMO, various guidelines are there. You can follow a guideline and keep the patient on follow-up with imaging as well as serum markers, right? Now, what if the patient has, you know, refractory disease, right? Or residual unresectable disease? Or recurrent disease. So in this scenario, you might have to go for second line treatment, right? Second line treatment is the standard. You cannot leave it there, especially if you have refractory disease with raised tumor markers or abnormal tumor markers. If you have significant residual disease, for example, in seminoma with PET-CT, FDG uptake, right? Or if you have residual disease that's unresectable, that is significant, or most importantly, most commonly, if you have recurrent disease, especially with your non-seminomatous germ cell tumors, you go for second line treatment. Second line treatment here, right, consists of the TIP regimen. So the TIP regimen, how do we give it, right? So that is what's important. So it's injection paclitaxel, 250 milligram per meter square, IV over 24 hours. This is given on day 1. This is followed by injection ifosfamide, 1.5 gram per meter square, IV. This is given day 2 to 5. And injection cisplatin, 25 milligram per meter square, IV, day 2 to 5. This is given every 3 weekly, and 4 cycles are given. Okay, 4 cycles are given, and of course you need to give primary prophylaxis because the risk for with growth factors, because the risk for febrile neutropenia is greater than 20%. Okay, so that is the second line salvage option. Overall, around 50% of the cases are salvageable, right? That is what you tend to see, and usually if the markers are normal, you resect regardless of the size. The size doesn't matter anymore in the second line setting. In the salvage setting, you resect all residual disease. Okay, so the markers are normal, you resect all residual disease post treatment. So, what is the role of transplant in second line setting? There is currently no definitive role for transplant. There's an ongoing Tiger trial which is looking at transplant, autologous transplant with, the TICE regimen, right? So TICE versus TIP. They're comparing the TIP regimen to TICE. So TICE consists of paclitaxel and ifosfamide, 3 cycles followed by, stem cell mobilization and collection, and then 3 tandem transplants with carboplatin and etoposide. Okay, they're comparing to TIP. The results are awaited. So we'll see whether the transplant has a role in the second line setting. We still do not know that. We are awaiting the results of the Tiger trial. Now, moving on, in the third line setting, suppose after second line chemotherapy, the markers are still raised or there's a recurrence, right? The third line setting, what are your options? So, generally in the third line setting, you would go for Gemox, right? Or you go for Gem-Pacli, or you can go for the VIP regimen, which consists of vinblastine, ifosfamide, and cisplatin. Okay. Now, after treating with these regimens, if you reduce the burden, there are multiple options. So you can take the patient up for transplant, autologous transplant with carboplatin and etoposide. That is an option if possible. Or if there's any residual disease, regardless of the markers. So in the third line setting, regardless of markers, you go for something called desperation surgery. Because we do not have any further effective lines of treatment, so you remove all the sites of disease regardless of the tumor markers. Okay, so these are the different options post third line. You can go for transplant or you can go for desperation surgery if there's any residual disease, regardless of the tumor markers. Okay. Now, transplant, there are a couple of criteria to look at whether the patient is eligible or will benefit from transplant. So you can just look this up. You have the Bears criteria, which is earlier used, and currently you have the IPFS criteria. That is the International Prognostic Factors Study criteria. Okay, the IPFS criteria. So both these criteria can be used to decide whether the patient will benefit from doing a transplant in the third line setting. Okay, right. So moving on. Now, the most important thing that you need to know here is the long-term sequelae of treating a germ cell tumor. Okay, because these most of these patients are curative, right? So because they are curative, a lot of these patients will develop long-term sequelae, and you need to monitor these patients in the surveillance period for those sequelae. So what are some of them? We'll just quickly go over them. So you can have cardiovascular effects, including metabolic syndrome, especially with cisplatin, which can cause metabolic syndrome. You can have dyslipidemia, hypertension, right? You can have diabetes, etc., and obesity. So all that can occur with cisplatin, especially. That's the main culprit. You can have neurotoxicity, especially because of cisplatin. And the interesting thing is that cisplatin-based neurotoxicity is irreversible mostly, unlike oxaliplatin-based neurotoxicity. Okay. And you can have infertility. Although baseline infertility is improved overall, but it can persist. You can also have hypogonadism. And if this is symptomatic, you might have to give testosterone replacement, right? You can have autotoxicity due to cisplatin. So this will present as sensorineural hearing loss. Although it is not very commonly seen, it is more common with children whose inner ears are more susceptible to cisplatin-based autotoxicity, right? Of course, you can have secondary malignancies. So this used to occur back in the day when RT was commonly given, right? So due to RT, although it is not preferred nowadays as a modality, then of course chemotherapy can also cause secondary malignancy. So the main culprit here is etoposide, especially in a cumulative dose, like we discussed earlier, of greater than 2 gram per meter square. There's a 5 to 6% or more risk of developing AML, right? Right. And so that can also be seen there. Okay. So, and of course, contralateral testicular malignancy, there's a 2 to 3% chance. So you always need to look out for that. Always physically examine the patient on follow-up, see if they develop a contralateral testicular malignancy. And of course, psychosocial functioning can also be impaired, and counseling and other, back to work, counseling as well needs to be done. Anxiety, depression, strains in relationships. Most of these patients are very young, so all of that can be seen, and psychosocial functioning is impaired. So counseling and psychological care is also very important. Okay. So yeah, regarding infertility, one more point to add is that always counsel the patient for sperm banking, right? So they'll look at the sperm quality, and if the quality is preserved, you can always go for sperm banking. If it's a female, we are talking about testicular GCTs, but you can also have GCTs in females rarely. In young patients, there also you go for cryopreservation. But in testicular GCT, if the sperm quality is maintained, you go for a sperm banking. Okay. So that is regarding the long-term toxicities. Now I will just end with a few pearls. We're trying to make this class as exhaustive as possible. I'll just end with a few pearls. So, primary medius channel GCT, right? If it is a seminoma, it usually comes under good risk. If there's non-pulmonary visceral mets, it comes under intermediate risk. Okay. So, there you treat with chemotherapy. Now, a non-seminomatous primary germ cell tumor, it automatically comes under poor risk. You should treat with 4 cycles of BEP or 4 cycles of VAP. Okay, so that is the difference. Seminoma mostly comes under good risk. Non-seminoma always comes under poor risk. Okay. Now, another site for this, primary germ cell tumors is the brain. So you can have germinomas. So in the brain, the seminoma is called germinoma. And you can also have non-germinomatous primary intracranial tumors. Okay. So in the brain, you can have primaries in the form of germinoma and also non-germinomatous primary brain tumors. So these usually occur in the suprasellular area and also in close proximity to the pineal gland. So germinoma usually, if it's not spread, if it's CSF is not affected, you go for intraventricular RT, which is definitive. In non-germinomatous, you go for chemotherapy, and you combine that with CSI usually because it's a high risk for CSF mets, especially if CSF is positive, right? So that is something to note. That's another primary site where GCTs can occur. Now, regarding children, so in the pediatric age group, you do not go for the BP regimen as such. There are a couple of other regimens that can be tried. So one is the PEB regimen. Okay, cisplatin, etoposide, and small b. Small b because what we do is because children are at a high propensity to develop pneumotoxicity due to bleomycin, you usually give a fixed dose of 15 units. Okay, 15 units is given on day 1. We omit the day 8 and 15 dose that is given in adults. So reduce dose and omitting the dose on day 8 and 15. So that is the PB regimen. Another regimen that has been explored is the JEB regimen. So here you give the lower dose of bleomycin and you replace cisplatin with carboplatin. Okay, because in pediatric patients at a higher risk, especially below the age of 10, at a higher risk for developing cisplatin-induced autotoxicity. You can replace cisplatin with carboplatin. Okay, so that is the JE small b regimen as well. So that brings us to the end of our long session. That is an exhaustive look at testicular germ cell tumors with some added pearls along the way regarding germ cell tumors of other sites. So hope you had a fruitful session. Please ask your doubts in the comment section and please give your feedback. Thank you very much.